I'm always interested when I meet people that I admire to hear about their early influences. Whether there was a teacher, an event, a set of events in your life that made you start thinking about values and perhaps even ethics.
Right. So I can't say that I thought about ethics per se as ethics. I don't think I really thought about that until much later on. But I would say that I was from a family that very much valued doing the right thing and talking about doing the right thing. So I think as an upbringing as a child that we were always talking about that. I think that some of the other things that influenced me more in the field, not only the values, but in thinking about science and how we learn and research, was a seventh grade science teacher. And I remember her name. Her name was Mrs. Clark. And she just turned me on to research, scientific inquiry, science, the importance of it. And it was right in seventh grade that I knew that whatever I wanted to do really had to be embedded within science. And so I look at that as a very formative thing in my life. I also remember she used to have the men and the women, or the girls and the boys, whatever you wanted to call us back in something, sort of compete. And so we would break when we were doing different exercises or different quizzes. She would do it fun, and the men and the women would compete. And it always made me sort of realize being a woman or a girl or whatever you wanted to call it, uh, doing that and almost getting competitive about, women can do things as well as men, especially in the sciences, because I remember at the time it was, you know, women didn't excel in the sciences. And I just remember wanting to keep up and do that. And so that was very formative for me for thinking about research, science, medicine. So that's how it really, my interest in science and research. I think the ethics piece I just sort of fell into and came later, but had maybe some formative thinking early on that I didn't even realize I had. Post high school, I went on to college. I wasn't sure where I was going to go. I ended up going to Brandeis University, and I used to kid and say that I got in under the dumb quota there. I was a great student. I love things, but my standardized scores were terrible, and I was very honored to go into Brandeis that had a very strong science program, and so that's exactly where I immersed myself in sciences, and I immersed myself in a typical pre-med program, and really thought that I wanted to go on to medical school. And Brandeis at that particular time was very, very competitive in the sciences, and people even sabotaged each other's experiments. I remember talking about research. I remember we had to do fruit fly mating experiments where we had to mate and remove the virgin fruit flies. And so we had to do this all weekend. And someone came into the lab and just let everyone's fruit flies go. And it was just terrible. And people used to steal each other's notebooks at exam times. It was not a pleasant experience. But despite that all, I stuck with the sciences and did what everyone else did and didn't do those things. And then decided towards the end that I didn't think that I wanted medical school, but I became very interested in genetic counseling. I had taken a genetics class there and an advanced class and really, really loved genetics. And so I explored, and that was just at the time when genetic counseling programs were being started. And some people said to me, if you're not a physician, you really can't do genetic counseling. And these were the very formative years. But I did apply. I applied to 5 schools at the time, and I didn't get accepted at 4, but 1 I got waitlisted, and I got out of college and decided that I should work to see what I got off the wait list. And so I got my first job after college. I ended up getting into the program. It was Sarah Lawrence University. But at that point had decided maybe I wasn't sure about that. And I was involved with who my husband is now and had thought about did I want to move there? Did he want to be here? And so I decided just to put it on hold for a year. And after that, got a job, worked at the VA administration as a coordinator for a study. And I think that study also influenced me because it was a clinical research study that involved diabetic amputees. And they were looking, I remember, at A1C levels, and they were giving them aspirin and different types of things. And so they taught me how to get in the lab and draw bloods, take the bloods up to the lab, process the bloods, do tests, collect data. I think the first time I watched blood being drawn, I remember someone teaching me, and just the thought of thinking that I was going to have to do it, I passed out in the room. And then the next time the gentleman came in, and he just sort of looked at me and said, "You're going to draw my blood?" And then I would bring it to the lab, and I was not a very good lab person. I knew by that point that lab things was not my skill set. So I had to find something else within research and not work in the lab. But I really enjoyed working with the people. And these were veterans and sometimes older people. And I'll never forget, there was one gentleman who had had one amputation, and he had to have a second, and he was in the study. And I remember being by his bedside when he woke up from his surgery, because I knew that no other family member was going to be there with him. So as the research coordinator, I remember waking up and just sort of holding his hand and talking to him during that time. So that I guess that's another formative thing in thinking about. I mean, that was more just as a person than as a research subject, that I was there for him. And I remained friendly many, many years with him, even after I left the job, and would send him cards at the holidays, and we would communicate. But I was there for a year, and I got another job as another research coordinator, and then that ended, and eventually got into the IRB world. I was working as a research coordinator on a 2-year contract that ended. The investigators that I was working with happened to be at Children's Hospital in Boston and at the Brigham. And that study was looking at people who had been irradiated for lymphoid hyperplasia and ended up developing thyroid cancer. And so in that job, it was interesting because in that job, I would trace people, go to vital records and trace people and try and find them, and then contact them out of the blue, and then coordinate having them come in for exams. But when the job was ending, I would be back and forth at the hospitals. I would just stop and look at the job boards. And while I was at Children's, I sort of saw something, and I pulled information and brought it home and just sort of had it sit on my desk for a while before, I put in an application for that. And that's how I got in. It was just a job, although it was obviously, I think it caught my eye because it had something to do with research, and I had had 2 jobs, but I had no idea. I had absolutely no idea what it was, what I'd be doing, or any of that. It was just sort of a leap of blind faith that this looked like something that might be interesting, and I needed a job. So it was 1983. And I remember my interview so well because the person who interviewed me his name was Dr. Albert Brazaghini, and he was the vice president, or whatever they called, of research administration at the time, and he had come up from NIH. That's where he had worked before he came to Children's. And so he knew that there about IRBs, and he had actually set up an IRB system at Children's. This was prior to me, because there was 2 other people for very short periods of time that began the IRB. But he had started that well before it was mandated, because he had heard rumblings at NIH that this was going to happen. So when he interviewed me, it's clear as day, I sat across this desk, and he asked me questions, and then he looked at me at the end. And he said, "One thing I want to ask you." And he looked at my hand, and he said, "I see you're married." He said, "When are you going to have children?" And as a young adult, young person who really wanted a job, you would never do that today. But I answered it. I mean, I wanted the job, and I didn't know how not to answer it. So I said, "Well, I'm young, but I'm not planning on having kids for a while." So that's one thing that I distinctly remember. The second thing is he finally looked at me and goes, you know, Susan, you seem like a really smart girl. And he used the word girl. And he said, I just want you to know, he said, I really don't think there's anything here for you. He said, I think 3 to 5 years, you'll get some skills, you'll learn things, and then you're probably going to have to find something else. And so with that, I was offered the job, and I accepted it. And just about 10 years ago, I had recontacted with him because he had left the hospital, and I hadn't had contact with him in a long time, and reminded him of that. So it was interesting that I was still there 30 years later. So, and it did turn out to be more than just a job. But I have to say, when I started, it was myself, and there was a part-time person who sort of helped, and no one knew what an IRB was. There wasn't any recognition of it. It was so different. So I think his comment was very genuine, given the time when, in 1983, when IRBs were just getting started and not really having a sense of where everything was going. So I don't fault him for saying that. I mean, who knew? Certainly I didn't know what was ahead of me and what was going to change in the world with research and IRBs and the importance of that.
So tell me, if you will, what you found when you went to your first IRB meeting or set out to learn what the IRB was like at Children's. How many people and how many protocols, and what would the rhythm of the meeting be like?
So the rhythm of the meeting, it was really interesting. The hospital had been functioning with an ethics type of review committee, and it actually morphed from other types of clinical research ethics issues. I mean, they sort of used it for a lot of things before it was actually mandated as an IRB. And I remember that I was extremely impressed by the sensitivity of everyone around the room and the thought. And I have to say, they really debated a lot, debated ethics. And it's interesting to think about that, because you'll talk to people now and say, oh, the good old days when we didn't have to deal with all the administrative types of things. We could really sit and talk about the ethics. And that's what I found. That's what I found. Now, perhaps I've always, at the hospital that I'm at, I've been very fortunate, and that's, I think, one of the reasons that I've never left, is that the culture of ethics is so ingrained in what they do. And it was there from day one. It was there before there were shutdowns. It was there before, there were other mandates and complexity and administrative things. It was there. It was in the core of the hospital. And so that made it very easy and interesting, and was a great way really to learn the ethics piece and to appreciate the importance of the ethics. Lots of the other stuff came later, and it's certainly important, but I think that was a lot of my training and exposure to that. There were, 10 or 12 people. It was always set up that when they started the committee, they took the most senior people and respected people, because they wanted it to feel important and for it to be recognized and have the clout. That's sometimes changed over the years with IRBs, because you want the least busy person or someone who doesn't have a committee. Everyone's very good. But it was very interesting the way that when I look back at who was on the committee, it was department heads. It was very strong and reputable people who were on the committee. And they reviewed a lot of things. Not all that dissimilar to the process used today. And certainly there was always a lot of research going on at the hospital. So there was no shortage of work.
Given your 30 years at one of the preeminent children's hospitals in the world, you've had a chance to not only confront, but certainly to shape a lot of the issues in research with children. And I wonder if you would tell me a little bit about your thinking and the hospital's policies on consent to research and assent, and the whole issue of determining competence in children.
So one of the things that always struck me that I learned very quickly in working with the researchers in the community is children are a lot smarter than we think, especially sick children. Sick children grow up really quickly, and I think that was always very much appreciated, the role of the child. Um, the hospital itself has always been very family centered and family decision making. And so what that means is involving the child in those things. So again, whether it's, Children's Hospital in Boston or any other type of children's hospital, that appreciation for the role of children and listening to children was always there, certainly in the clinical world, and I think really translated to the research environment. So when we have discussions about children's role, their assent and their involvement in their decision making, it always felt very, very natural. And I think recognizing children of different ages and how you have to do things differently. And then also very quickly recognizing the upper age of the spectrum when teens are very capable of making their own decisions and letting them, be very, very involved. So I always felt, I mean, maybe people think, this is progressive in the thinking of, in the research ethics world, but starting 30 years ago, this was something that I quickly realized when I worked with the committee. I think, the issue of written assent forms and having people sign that, I mean, I think that's sort of taken a life of its own. And I think there are a lot of individuals, including myself, that feel that that's not where we, especially in dealing with children, that that's not where the emphasis should be. That the emphasis should be on dialogue and discussion with children at whatever level they are capable of doing that. So where a lot of institutions quickly required written forms, for different age groups, for many years, and including now, we have a lot of things that we don't. We really emphasize the verbal and the discussion before, involving children in the assent process. So, I've learned a lot. And also, I'll share an interesting story that happened probably about 10 years ago that relates to this. A research coordinator had called me and said to me that there was a 13-year-old child who had been asked to provide assent and had said no. However, the parents wanted the child to participate in the research. And the question to me, which I'm glad came to me, was how much should we pressure the child? And so, first thing I said, first of all, we don't pressure the child. Let's stop there. So, and I thank them very much for calling me. And it turns out that when I asked a little more information, that this was a 14-year-old child who had had a transplant, had a kidney disease from very young on, had always been to the hospital back and forth, and that this particular research was really looking at combinations of drugs, and that involved some extra blood tests or scans or whatever, but really didn't involve any investigational drugs. And this particular child knew that he could get the same drugs, the same care, and not be in the research. So when the call came in, I called the IRB chair and said, how do we guide? And they said, well, let's have someone independent. Let's have someone independent to the research team. Maybe if there's a social worker or someone else, go and talk to the child to sort of understand, ask them what they're thinking and talk to the parents. And so the social worker went in and spoke to the child, and the child clearly said, he said, I've been a patient here for a long time. I haven't had any ability to make any decisions about my medical care. He said, I have a decision to make. Someone asked me to think about this. I have a decision to make. I know I can get care. I know I can get the drugs. I just want to say no. And so, what that child at 13 was doing was asserting their developing autonomy. And I think once we pointed that out to the investigator and to the team, there was no question they weren't going to enroll the child, because it made a lot of sense. It made a lot of sense what that child was doing. So, those are interesting things when we think about, do children, and this was a 13-year-old, certainly not a child, but still not an adult in their thinking, they're smart. They can think about these things. They can be asked. And that was a great example of that to me.
During your tenure at Children's, you really have developed one of the flagship programs again in the country, if not the world. And I wonder if you have thought about, or if you could think about today, what some of your proudest achievements are during your time in the job.
So I think one of my proudest achievements is that I feel that what I personally have done, and what certainly I've trained staff and many people, it's not just me, it's so many people in my office that we hire and work, is that we often get a lot of feedback about how people appreciate working with our office. And I think what I've come to appreciate is that I view our role in the IRB and in the ethics world as a collaborator with investigators. And I live that in the office, and I talk to people in the office when I hire them. And that's what we are. We don't consider ourselves a compliance office. There's a huge compliance component, but we don't talk about that. We talk about collaborating. And I always tell our staff and our people that I train that if you're doing research and you need biostatistical help, you very freely recognize that you may not have that expertise, and so you go to a biostatistician. So why can't it be recognized that if you need assistance, or you need a peer review or some other type of outside view, why can't you recognize the committee, the people, the staff is that for you as a collaborator with you? And I've come to realize that, it's gotten a lot better, but that's not people don't go to medical school generally to learn about how to do research and ethics and regulations. And I've learned that you can't always expect that. You can expect a certain level, but then what our role is to help them. And I've received enough comments from faculty who have come from other places and other centers, and have received, notices or whatever, thank you, I think you really, helped. Now, there's certainly people who grumble and look at things bureaucratically, but I think I feel very, very good about that, and being able to maintain that, and to be able to maintain that that approach in the office, even at times when institutions were being shut down and everyone was looking at all the compliance things. I feel like I've maintained a sense of sanity of what an IRB office should be doing. And if you do it with that approach, the compliance piece just sort of comes along with it. That's not the main focus, but that comes along with it. And so I would always tell our staff, never say to someone, you have to do this because of the regs. That's like the absolute worst thing to say, but to do it because it's the ethical or right thing to do. And, there is a regulatory component that, we need to consider as well. So I think that's one of the, the proudest things in general, that I've done at the hospital. The most fun thing I'm working on right now is I'm working with a faculty member who has an interest in comic books, and has used comic books to help teach children. He's a gastroenterologist, so he's done a lot with Crohn's and colitis and obesity. And he works with very well-known cartoonists. It's a husband and a wife team where the husband does the drawings and the wife does the storyline. And so we're developing a comic book that's going to be what is research, to help educate children about research, not any particular project, but to have available in the waiting rooms, in the sitting rooms, on the web, to help educate children about research and about being a research subject, and then also thinking about things that they want to think about or ask. And so that's one of the the more interesting creative things that I'm working on now. And it's been a lot of fun. I saw just about 2 weeks ago the first script, and we have a cute storyline about a child who's being asked to participate in research and goes home and talks to his nerdy sister, and she wants to learn about research for a science project, and they interview people, and it's going to be fun. So that's one project that's sort of fun. There's obviously there's a lot of other projects that have to deal with more administrative projects, but I always like to do something with sort of the big picture in mind and get out of the weeds of the administration piece. So
Finding your job at Children's and starting there coincided quite closely with the beginning of the HIV/AIDS pandemic.
yes.
And clearly, the impact it had on those children infected with HIV/AIDS was profound. And I wonder if you might tell me
Sure.
something about what it was like to be involved in a children's hospital at that time.
It's quite amazing to look back at the AIDS epidemic, and the original, one of the first that we called the 076 trial. It was the fetal transmission trial, where the idea that you would give women AZT to prevent it from transmission in children. And we had no idea that it worked. So in hindsight, it's very, very different. That trial was reviewed at Children's. And I'll never forget, it was so contentious. It's an interesting story. It was so contentious that our IRB actually turned it down. We voted against it after a lot of discussion. And this was one of these things that you don't like to happen in an IRB, but unfortunately, somehow, how people voted got outside of the IRB. And to the point where the investigator somehow got information about who voted what way. I mean, this is an IRB's nightmare. And I lived through that nightmare. And so the person who was running that trial knew who voted which way, and there were people, IRB members, that were being lobbied, the people who were voted, against it. It was a mess. It was an absolute nightmare. The end result, right or wrong, was that there at a later date there was a resubmission. There was some other data that came in also at the time. That it was reconsidered, and it eventually was passed at the hospital. I hate to think that breach of confidentiality caused a reconsideration. I think there are other factors. I think probably it would have been brought back to us for some other reasons. I think that may have certainly fueled things. But that was sort of, and it was passed, and we did do the trial. And as we all know, these were very important trials because it did reduce the transmission of HIV to infants. So I remember that very, very well. Now, in the field in general, I do remember, this was the time when the FDA, when the AIDS activists lobbied very hard, very ardently, because many times, and this was not children, although it may have been some children, the only way you could get care was to get on a trial with drugs. And there were stories of people, of investigators falsifying data on patients to be able to get them access. So there was all of that going on in the community. But the important thing is that FDA, this was the time when FDA started to recognize the need to find other mechanisms to get drugs to people quicker. And so a lot of the quicker, fast path mechanisms that we have today, so that you can allow certain drugs to be used, an investigational drug, once you have a certain amount of data on a trial, or other types of compassionate use or fast track. That was all based on the HIV epidemic and the activism of those with HIV. And I think it served us well. I mean, it was just for HIV, but there are many other diseases and diagnoses that are as important, where people don't have other options and do want access to investigational drugs earlier than waiting for all the trials to be completed. And I just remember thinking about that and thinking about, is this a good thing? They're allowing other paths to get drugs, but we don't have the data yet. And sort of thinking in my mind, do we have to, the issue of, protect or someone's right if they understand that it hasn't been approved but want it. And that tension still exists today in many things. It's, part of the pendulum that has swung from protectionism to your right to, your extreme right to have access to investigational drugs. And there have been lawsuits trying to do that. But the AIDS epidemic really sort of brought that to the forefront, and also in a very good way did allow the FDA to have new channels to allow drugs to be accessible to individuals sooner. So that was a good thing. I remember it clearly.
And another issue that similarly has really gained traction and certainly visibility is that of international research.
Right.
The past 30 years, particularly as funding has shifted, funding sources have shifted. I wonder if you could talk a little bit about how the shift to offshore research has changed the way or impacted the way research is performed today.
Sure. I can honestly say that 30 years ago, we had, in my experience, there was no one who was doing, work overseas. I mean, or international research from our hospital. It was very, very rare that it was done. It could have been done, but we just didn't hear about it. We didn't review it. We didn't have to think about it. We didn't have to think about, the issues. And, gradually over the years, we've seen more and more investigators as the world has gotten smaller, and we have more cooperative efforts and needs for cooperative efforts and needs to have trials in different places of the same drugs, or the needs to explore issues that are very pertinent to a particular culture, and our investigators being very interested in collaborating. So we've seen a real growth in that particular area, as everyone else, and also a huge number of challenges in doing that, and especially in dealing within pediatric areas as well. It's not as easy. As I've gotten more involved and I've gotten to be able to go to other cultures and to teach, it's very, very, very complex. And you often talk to people internationally, and they all want to be like the United States. What do you do? They all want to be, but when you start really sort of pulling apart the research and the ethics issues, it doesn't match up. It just doesn't match up. And so this desire for everyone to want to understand, to follow the regs, it can be very, very, very complex. One of the interesting things that recently happened is we spend a lot of time in the United States talking about research-related injuries. Who's going to pay research-related injuries? And in certain countries now, there's certain mandates, about that. In certain countries, they don't have insurance like we do. There's more socialized medicine, so it's not a particular, issue. Another example is paying a research participant. I mean, that's like unheard of. I went to lecture this past summer in Turkey, and I had brought some cases. They all wanted cases, and so I had been talking to some people before we were going to do cases, and this idea that you would get paid was that doesn't happen. And so here I was, with my cases, having to change things, at the very last minute, because those were not issues, and payment for research injuries were not issues. And so it's very, very, very complex. And I think we have to rely. I'm so glad that there's so much more effort to have international countries do to help them learn to think on their own. I think that's the best that we can do, to raise the issues and have them think and solve their own problems, and think about best ways of addressing things. Because time and time again, our IRB will review something that's international, and we'll just get feedback that we are just so way off base. That's just not an issue. Another example where so we were reviewing a protocol for one of the resource poor countries, and I forget it was one in Africa, and there was all this information in the protocol about maintaining communication with people via cell phones now, and phone. And so if our IRB sat around and go, this is resource poor, how are they going to do this? People don't have phones. Well, they all do have phones. I mean, they may not have a lot of other things, but in the setting we were at, they all did have phones. And so we spent a lot of time talking about how are you going to do this, and it turns out, after we really got information that, they may not have other types of things, but they do have phones. And that is the way that people, communicated. And it is rather inexpensive for people to have phones. So, it goes both ways, where we think, here we have such technology, and a resource poor country would not, and it didn't go that way. And then other things that, go the opposite way. And it gets complex with children and issues of certainly of maturity and assent. We're constantly learning that in a lot of countries, a 12-year-old mom can bring their child in and be cared for, and they don't need parental permission. And I've just learned you can't assume anything, and you really need the depth there.
So HIV/AIDS was a big disease-related event in the last 30 years. The move to resource poor and other offshore research sites was big. In this country, in the late 90s, there were a lot of shutdowns. And I wonder if you could tell me how that was perceived and refracted through your experience and
Right.
perch at that point in time. That was
Right. So, I will admit, I was on one of the site visits with OHRP that ultimately did lead to a shutdown. It was a situation where we went and found lots of things, and the institution chose not to address it, and then was shut down because of that. But it was interesting, because in that situation, and I'll talk about the shutdowns, but I'll also talk about something else. In that situation, when we went and interviewed, members of the staff and the faculty and whatever at that site, everyone said how much they loved their IRB. And I kept thinking to myself, how can someone really love their IRB? Everything was, I love, they're great, they're fast. And at that point I said, something may not be right here, because you can appreciate, you can have good comments, but there's always got to be what I consider this healthy tension, And so to me that was a clue, and it turned out that's exactly what the issue was, that IRB did not have the resources to be doing what it should be doing, and that things were not being handled the way they should. And eventually that IRB, was shut down, not because, like I said, because they didn't have a list of things to clean up. They just sort of ignored it in the end. But to me, that sort of was an example of sort of what was going on. And I don't think that institution was alone. I mean, it may have been an extreme, but I honestly think, because many of us, at least in the administrative area of IRBs, just kept saying, by the grace of God, it could be me. And so it was horrible that these things happened, certainly. It caused an incredible amount of problems, issues, money lost, investigators' careers, all of that. But in the end, I have to say, it called attention to something that needed attention called to it. And I was always very fortunate to have an institution that recognized resources, but there weren't many that didn't. And so this was a wake-up call. Now, I think what happened was that everyone got so scared. The pendulum swung so that you didn't want to do anything, and everyone started, being so overcautious and overburdening that you forgot to look at some flexibility. There was sort of an insanity that resulted because of that. But I think overall, it did call attention. I mean, people knew what the word IRB was after those shutdowns. And so is that a bad thing? I don't think that was a bad thing. I don't know how, I wish it could have been a little bit different so that we weren't in such an era that we were so afraid. I mean, I can remember, my husband is an internal auditor. And I can remember at that particular time, all of a sudden now, all of the universities and hospitals, their internal audit departments were going crazy because this was like a risk. And this was something no one even knew about or paid attention to. So all of a sudden, all the internal audit offices were being told, you got to go to the IRB. You got to speak to them, including my husband. Well, when they found out that my husband was married to someone who works with an IRB, I actually was asked to go to 2 conferences of university internal auditors and present with him, which is another story, but to talk about this because all of a sudden this became something that people wanted to know about. Now, did internal audit go and do good audits? I don't want to comment on that. But the fact that institutions and those who led institutions and who were thinking about things were aware of that, I think that there was something positive that that came out of it. I think it's just one of those things. It was unfortunate it had to happen. I think there was a silver lining a little bit to it, but I think we're still trying to now take advantage of what was good, but try and undo what was not good, the overreactivity, which has lived on and has been concerning as well.
Thank you. So stepping away from your specific job for a bit, I'd like to hear about your introduction to Primer. As you well know, and as we luckily have benefited from, you've been indispensable to the organization. So I'd like to hear about your introduction to Primer and how you first came to be involved with the organization.
Joan, it's so hard. I honestly thought about that. I know I've been involved for a while. And I know people said to me, you got to go to Primer, and I went. But it was sort of one of those things like, okay, I'll go. It just sort of, showed up there. And it's sort of, I don't have sort of a clear, distinct, remembering of what of getting in, of coming and getting involved. I just remember sort of being there and going. I also remember, that I liked it when I went, and I liked it because there were other people like me there, and that was like the most important thing because I felt very isolated. And if I felt isolated in Boston, but we, with other people around and other IRB things, but in the beginning we didn't interact and do that much. So I remember that was like incredible to me. I also remember, and it's so different now when we think about Primer meetings, I also remember going to every workshop and just lapping everything up. And I remember sitting at the plenaries going, who thinks about these things, Because as Primer, as we've set things up, the plenaries are the 1,000-foot level, the more, difficult issues, the workshops, at least initially were all that nitty-gritty. And I just wanted all that nitty-gritty because that's what I needed for my particular job. I didn't consider myself sort of a big thinker at that time. And it's interesting that over the years, how that's changed. But I mean, that's sort of the growth of things. So, I think about going and, meeting people, feeling a community, and like really learning. And then I remember the first time, it was because of primer, really the first time I had done, I remember being asked for, and you approaching me and doing some workshops and around pediatrics, which I felt comfortable with. But then I also remember the first time I gave and this is in my career, was the first time I gave a big talk. And that was the first year I think that we were in San Diego. And I remember, I gave, a bigger talk. And I remember how scared and nervous I was. But that was such a turning point for me that someone, recognized that they wanted to hear me, that they thought it was, meaningful to hear me. I hope I did okay when I did it. But that was such a turning point in my career, in my confidence, and also in what I felt I could offer, and feeling that I could do more. And that was I'll never forget that that someone had sort of seen something, um, and it was really, I have to say, it was really through primer that I think I've gained my ability to think, to do, to want to help others, and to have a forum to do it. I think that's really what is very, very, very important, to me and to many others, and something that I think, we always have to be able to do, at Primer, for everyone at every level, whether you're a chair. And it's very interesting because this past meeting, I had one of our chairs come for the first time, and I had actually two of our chairs. I had a lot of people come, and they came back just buzzing about the conference. And also, it was interesting because they all recognized other colleagues that they know in their disciplines who were also there, like, oh, you do that? You're doing this all too. And so they felt a sense of community there. So whether you're an administrator, whether you're a chair or whatever, there was a sense of community there and learning. And I'm very thankful for that, as I think many